Hi everyone, I am Dr. Sagar Sahu and welcome to Vet Surgery at Age. So today I welcome you to another lecture on the radiographic pathology. So today we will be discussing the excretory system, the kidney, ureter and the bladder and then the urethra. Okay, before this lecture there has been 3 lectures on radiography. First one is the abdomen, normal abdomen, second is normal thorax and third is the radiography pathology of peritoneum, liver and spleen. If you haven't watched those videos, please do watch them before watching this one. Okay, so that you will know that how these things are taught. So today we will be discussing the excretory system, okay, mostly the renal system. So first let us go to the kidney, okay, kidney. So this is the radiography picture of a dog. The dog kidneys are usually oval, they are oval in shape, okay. The right kidney usually located at the level of T13 and the left kidney is located at the level of L1 to L3. It is not exactly in every dog, okay. This is a reference mark which you can note to locate those kidneys, okay. Also the renal length to L2 ratio. If you have not watched the normal abdominal radiograph video, do watch them. What is the renal length to L2 ratio? What this is, okay. So renal length to L2 ratio for dog is 2.5 to 3.5. If it is beyond 3.5, then exactly if it is 3.6, it's all right, okay. If it is more than some, if it is significantly more, then it may be a case of renomegaly. If it is significantly less, then it may be renal hypoplasia. Okay, so here see, this is one kidney, this is another kidney. Okay, the cranial one is the right kidney and the caudal one is the left kidney. Here this is a triangular shape which is slightly superimposed on the right kidney is the spleen. Okay, so this is lateral view, this is dorsoventral view or ventrodorsal view. This is the left kidney and here this is the right kidney. Okay, I told you right kidney is at level of T13. This is T13. Okay, it may not be true for every dog, but most of the dog you will find at the level of T13. The cranial pole, this is the cranial pole of this right kidney, will share the border with the liver. Due to this border effacement between the liver and kidney, usually the right kidney's this cranial pole is not visible, and also the right kidney is not consistently visible in dogs. The left kidney is very much consistent. You can find in every species the visibility of the left kidney. These are some normal parameters of kidney in case of dog. Okay, let us go to the cat. This is cat, radiograph of cat. Due to very good renal fat, they have excellent view. Okay, so here can you see, this is one kidney, this is another kidney. Both the kidney has been superimposed at this point. It looks like a Venn diagram in mathematics. Okay. So due to this superimposition, the radio opacity has been increased. This is not a renolith, only due to the superimposition the radio opacity has been increased. Now the notice this slightly radio opaque area, radiolucent area. Can you mark this one? I am erasing it. Mark this one. Okay, here and also here. Okay, these are hilus, renal hilus. Due to very good renal fat in case of cat, you may get visualization of this renal hilus. Now some normal parameters, they are usually rounder than the dog. Okay, round to oval, more or less roundish comparing to the dogs, and the location is basically from L1 to L4. And the renal length to L2 ratio is usually ranges between 2.4 to 3. But you have to remember one thing, in case of neutered cats and also in case of old cats, okay, this lesser value can go up to 1.9. okay, they have slightly smaller cat. Neutered cat has smaller kidney. Neutered cat has a smaller kidney compared to intact cat. Also the old cats, they have very small kidney. They may go up to 1.9, the reference range 1.9 to 2.4. Up to this range they may have smaller kidneys. Okay, so we have to keep these things in mind. So this is the lateral radiograph, the left one. The right one is the dorsoventral or ventrodorsal. Okay, this one is one kidney. The other kidney is not that visible. Okay, here is the kidney, but it is not that visible due to this colon. Okay, this is descending colon, transverse, and the ascending colon. Okay, I have already discussed these colons in normal radiography. Okay, normal abdominal radiography. If you have not watched those videos, do watch them. Now let us go to the technique through which kidneys are evaluated mostly. It is excretory urography. Excretory urography, in which you will be administering some contrast agents to give a good contrast, so that you can visualize the kidneys better. So there is a procedure for this excretory urography. You have to withhold the food for 12 to 24 hours, not water. Withdrawing food is the main reason behind that. The main reason behind this is the colons will be empty. Okay, they will not hinder any problem. They will not hinder, especially the ureters. Okay, so that is why the food is withdrawn. If the animal has taken some food, you can use enema to evacuate the colons. Okay, now the patient should be hydrated. There is a contraindication for excretory urography is dehydration. Okay, in dehydrated patients you should not use this method. First you have to give fluid therapy and do the hydration, then after do the urography. That is why the food is withheld but not the water. Water should be given sufficiently. There is another case in which it is contraindicated, is anuria or kidney failure. Okay, also in case of hypotension you should not use this method, hypotension, and if there is previous history of hypersensitivity, especially to the contrast agent, hypersensitivity. Now, so patient should be hydrated. Before doing the procedure, take a survey radiograph for comparison. Okay. Now use sedation or general anesthesia, which method you are more comfortable with. Then place the IV catheter. Then administer the contrast agent, usually the iodine contrast agent. The dose rate is 600 to 700 mg per kg. In some articles, even in some books, you may go up to the reference may go up to 800 mg per kg body weight. Okay, so after giving the contrast agent, you have to take radiographs exactly or immediately after the giving the contrast agent, then after 5, 20, 40, or if you are doing some research where you need lesser interval, then you can take the radiograph. But the thing is, you have to take the lateral radiograph, both the right and left. Also you have to take a VD and oblique views. Okay, slightly oblique. The VD view, if you will slightly tilt it, then it becomes a oblique view. Oblique view are very much essential for evaluating the ureters. Okay, so you have to take oblique view. Remember, it should be taken immediately. In books you will find it should be taken 5 to 7 seconds after the administering the contrast agent. Okay, it is just immediate. Okay, now let us see the images. So this extreme left one is normal survey radiograph. You can see here is the kidney. The cranial pole has some border sharing with the stomach. Okay, now after giving the contrast agent or performing the excretory urography, it has two phases. The first phase is nephrogram phase. Nephrogram. In this phase, the parenchyma will be opacified. Okay, the opacity of the parenchyma will be increased, and this typically on an average begins at the 10 second and lasts up to 2 minutes. Okay, it may vary different from patient to patient, from dog to dog, from cat to cat. Okay, but the average is 10 second to 2 minutes. This is nephrogram phase. See the nephrogram phase. The entire parenchyma has been opacified and you can visualize very good parenchymas, the kidney structure actually. Next phase is the pyelogram phase. Pyelogram phase. So in this phase, what will happen? In this phase, some structures will be opacified, like the diverticulum, renal diverticulum, and the renal pelvis, and also the ureter. These are basically the collecting systems through which urines are collected. So these structures will be opacified. Can you see these structures? Okay, I am drawing. Notice these things. Here is some opacity like this. Okay, like this, like this, like this. These are diverticulums. This structure here is the pelvis, and from that the ureter is coming out. Okay, now I am erasing. Notice those structures. Okay, they are basically shades of gray. Okay, so you have to be very careful. Okay, see here, 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 there are some radiolucency, and these are opaque area. These are basically diverticulums. These are diverticulums. Okay, now they will join to form the renal pelvis. Here is the pelvis, and this is the ureter. Okay, so remember those two phases, the nephrogram phase and the pyelogram phase. Now let us see another radiograph. See this here, the another technique has been used to evaluate the renal system. This is antegrade ultrasound guided urography. Okay, what will happen in this? They will deposit the contrast agent directly into the pelvis by the method by ultrasound. Okay, they will insert a needle through guidance of ultrasound. They will directly deposit in the renal pelvis the contrast agent, the iodinated contrast agents. So here you see the diverticulums are very nicely visualized in case of cats. Most of the cats will have very nice diverticulum which can be visualized in urography. Okay, excretory urography. You will find very less dogs in which it is usually visualized. That structure, in that structure you can see that it is not so nice, but here you see they are very nice. Can you see these pointed structures? Okay, these are diverticulums, and this structure is the pelvis, renal pelvis, and from which the ureter is coming out. Now notice the kidneys. Here is one kidney. Okay, they are slightly superimposed. You can see those ureters actually. The cranial one is the right, the caudal one is the left. Okay, but here you can see one kidney and there is another kidney like that. Okay, so these ureters will be going and joining into the neck of the bladder. Bladder has three parts: the apex, the body, and the neck. Okay, so we will discuss the bladder later. Now see the ureters. Okay, now let us see in dorsoventral view. See here, see this diverticulum. These are diverticulums. This is pelvis, and ureter is coming. This is left side ureter. Ureter is coming, and before ending in the neck of the bladder, they migrate slightly cranially and end on the dorsal aspect of the neck of the bladder. Okay, and this is bladder. This bladder is faulty. Okay, some pathology is there because there is not even killing of these contrast mediums. Okay, we will discuss the bladder later. Now this is right side. Sorry, this is the left side. I am sorry again. This is the right side. These are the diverticulums, renal pelvis. This is the ureter. Okay, very tortuous structure, and they're like this. The cranial migration of these ureters. Okay, these are normal structures. Let us go into some pathology. Okay, first pathology is renomegaly. You see, for renomegaly there may be many regions. It may be a case of cyst, it may be a case of abscess, it may become some tumor mass or neoplasia. Okay, they are better evaluated ultrasonographically. But there are some things which can be visualized grossly. Like renomegaly, it can be visualized in X-ray. Here you see this is one kidney, and here is another kidney. The cranial one is the right, and the caudal one is the left. Okay, they are very big. Okay, now let us see in the dorsoventral view or ventrodorsal view. See this. This is kidney is so big, and the cortical margin or the renal capsule is uneven. Okay, here one and here is another one. Okay, this is renomegaly. If you will take the renal length to the T13, L1 and L2, renal length to L2 ratio, it will be beyond 3.5. Okay, this is case of renomegaly. This is bilateral renomegaly. Both the left and the right kidneys has been enlarged. Okay, if you want to further study, then it is better go for the ultrasonography rather than the X-ray. Now let us see some unilateral. This is left hand side. Okay, so when there will be renomegaly, you will find the intestines ventrally. Okay, they will pushed ventrally. But see here, if you have seen the peritoneal space video, many times here you will find splenic tumors. So how to differentiate them? It may be a splenic tumor. Initially you may differentiate between those things. So one thing you have to see, the kidneys are in retroperitoneal space, while the spleen is in peritoneal space. See the retroperitoneal space. Okay, you can see very thin margin. Okay, so like this, this is the kidney is in the retroperitoneal space. Okay, so that is in that way you can differentiate that whether this is kidney enlargement or this spleen enlargement. Okay, so this is the enlargement of left kidney. Here in the ventrodorsal view, you will see normally here you will find the descending colon, but due to renomegaly, the descending colon has been shifted to right hand side. This is the left side, this is right hand side. So it has been shifted to right hand side. So these are the signs you have to look for while dealing with X-ray, especially the intestines. I told you the jejunomes are comparatively more free. If you have not watched those videos, please watch peritoneal space, liver and spleen. So due to this jejunum, position of jejunum can tell you where the pathology lies. Okay, and also the shifting of these intestines. Okay, you need orthogonal views, at least 2 views to evaluate the kidneys. So this is the renomegaly left, and another, this one is the right renomegaly. You see, when tumor mass is too big, there is ambiguity, or you may feel helpless regarding the identification of which tumor is this. Sometimes you have to go for exploratory laparatory. Okay, or you can do better is ultrasound. Ultrasound is a very superior technique than the radiography to evaluate soft tissues. Okay, not the hard tissues. So here you see, this is the big mass here. Okay, so here you see this one is the enlargement. Here you notice in this radiograph, lateral radiograph, notice the duodenum. Okay, this is pylorus. Here is the fundus, this is pylorus. The duodenum is supposed to go like this. Okay, like this, but instead going like that, it has come to ventral side. Okay, so ventral displacement of duodenum is a sign of renomegaly, especially the right hand side renomegaly. Okay, here you see the duodenum is on the left side. Here is the duodenum. Sorry, see, can you see this duodenum? Okay, very thin structure, duodenum. And another thing, the ascending colon. Here should be descending, transverse and ascending colon. You see, this is ascending colon, transverse colon and the descending colon. The ascending colon, which should be on the right side, has been pushed to the left side. Okay, by looking at this all, then you have to diagnose the disease. Okay, now let us go to other pathologies. Next is renal hypoplasia. Renal hypoplasia is basically seen in case of CKD, chronic kidney disease. Chronic kidney disease most commonly, though you may find in other cases also. Here you see a small kidney. Okay, this is a kidney, and here some mineralization. Okay, these are basically nephroliths. Okay, a renal mineralization. The right kidney is not that visible, but you can see the mineralization. Okay, now let us go to the dorsoventral or ventrodorsal view. See the kidney size. Okay, this is very small kidney. Okay, if you will take ratio of this renal length to L2, this is T13, L1 and L2, then you will find less than 2.5. Just look at it, it is not even twice of this L2. Okay, very less. So these are small kidneys, renal hypoplasia. Okay, so in case of CKD, you may find also cortical infarctions. Okay, let me show you some radiograph. See, here there are two kidneys. Notice them. Here is one kidney and another kidney is here. See, here it should be like this, but instead of like that, you see this like this. This is cortical infection. Due to cortical infection, some portion of cortex is lost. Or okay, so these are cortical infections which you may find in case of CKD. And notice also this is a renal mineralization, nephrolith. Another thing, notice these two structures. Here one and here another one. These are ureter stones. In case of cat, due to good retroperitoneal fat, you may find the ureter stones also in survey radiograph. Otherwise, you have to go for excretory urography. Okay. So these are ureter stones. We'll discuss the ureter also. So this is pathology, or that is renal cyst. So in case of renal cyst, you will find that the cortical margin or the renal capsule is irregular. Okay, there will be renomegaly and also there will be irregular. See the margin. Here it comes like this, some undulations like this. Okay, here the another kidney is here. Let us see in the ventrodorsal so that you can appreciate better. You see here the margins, the renal capsule is undulating. Okay, so you see if there is very small cyst, okay, you may not notice in the radiograph, which can be diagnosed in ultrasonography. Okay, ultrasonography is better. When they are sufficiently enlarged, then you can identify in the radiograph. Okay, so it is better to go for ultrasonography to evaluate kidney in early stages. In late stages, you can find like this. So this is characteristics. The undulating renal capsule or irregular renal capsule is characteristics for a renal cyst. Next, pyelonephritis. Okay, so I told you. So this is left. This is right. See the difference. This is one is the normal one. This is one is the pathological one. Notice here in the normal one. See these structures, radiating structures. They are basically the diverticulums. Here is the pelvis, and here is the ureter, which is originating. But notice the contralateral side. That is the right hand side. You see the diverticulums are now blunt. So blunting of the diverticulum, and also the renal pelvis is enlarged. Okay, so enlargement of renal pelvis. For this, it is better to go for ultrasonography to measure those pelvis, everything. And also the ureter is enlarged or dilated comparative to the normal one. Okay, so this is the sign. These are the blunting of the diverticulum and enlargement of or dilation of the renal pelvis is a characteristic sign for the pyelonephritis. Okay, pyelonephritis is inflammation of the collecting systems. Okay, see here hydronephrosis. Hydronephrosis is usually associated with the ureter stones. Okay, then when there will be some blockage in your ureter, the water will be retained inside the kidney, resulting in hydronephrosis. So this is the left side, this is the right side. Right side is now normal. See these radiating structures, diverticulum, pelvis and the ureter. Okay, but here you see the kidney is first of all enlarged and the border, the renal capsule is undulating, which you may say that, or you can say irregular, which you may say that it may be case of renal cyst. But notice other things. See the pelvis. This is the entirely renal pelvis. Okay, there is very thin cortex, and also notice the interlobal vessels. These are interlobar vessels, which is radiating like spoke. Okay, in bikes we have a spoke, so radiating like spoke. These are characteristics for the hydronephrosis. When you will do excretory urogram, you will find filling defect. I will discuss what is filling defect in ureter, and also you will find some hydronephrosis change. You see, this is a extreme case or severe case. Okay, for very acute case, or you can say at early stages, it is better to go for ultrasonography rather than radiography. Okay. Now, let us see some ureteral obstructions. I told you about antegrade ultrasound guided urography. This is the method. Through you see there is a needle which has been inserted to the kidney pelvis. Okay, ultrasound guided. Then the contrast agent has been given. See these two kidneys. Here is one kidney. Here is another kidney. This is the right kidney. This is the left kidney. First of all, the antegrade urography has been done for the right kidney. Okay, now see. You see the diverticulum is there, but slightly blunting is there, and also the pelvis is slightly bigger. Notice the ureter. This is too big. Okay, this is hydronephrosis. Now see, and see the contrast has been agent has gone up to this level, but it is not going to the bladder. This is known as filling defect. Okay, the contrast has been filled up to this level, but there is no further filling. This is filling defect. Okay, so you can suggest that there is some blockage in this area. Let us see on the other side. Here you see the left kidney. Here is the left kidney. Sorry. Yes. This one is the left kidney. So here when the antegrade urography has been done, notice. Okay, first of all the diverticulums are clearly visualized, and notice there is some dilation of the renal pelvis, but the ureter is intact. See the migration. There is cranial migration of this cranial, in the cranial direction they will bend, and then it goes into the bladder. It means that the left ureter is intact, while the right ureter, you can see their right kidney is also enlarged. There is some hydronephrosis or some pathology in this kidney, and due to this ureter blockage. Okay, this is filling, technically is known as filling defect of ureter. So you can see here clearly. Okay, so this is basically the ureteral obstruction. Sometimes you may find ureteral obstruction, especially stones, in survey radiographs. Otherwise you can go for exploratory urography. Here you see I had already shown you this image. There is another thing is known as compression radiography for to add see the ureter stones. Okay, so here this is normal radiograph, survey radiograph. Can you see a point here? You have to very vigilant, very careful while looking into these radiographs. Okay, can you see here? But the problem is the descending colon is interfering with this one. So what is compression radiography? So you will compress this portion with some radiolucent material like wood. Okay, you can compress this one. When you will compress this descending colon will migrate to the abdominal wall, towards the lateral side, like here. Okay, so when it has been moved towards the lateral side, now the retroperitoneal space has been very clear, and you can visualize the stone better. This is known as compression radiography, especially for ureter calculi. Okay, to visualize mostly the distal part of ureter, when the descending colon is much more interfering. Okay, this is compression radiography. Now let us go to ectopic ureter. Ectopic ureter means the ureter which is supposed to end or supposed to join the bladder at the neck. It may not end at that portion, dorsal portion of neck. It may go further, or the proximal urethra or distal urethra. It may go up to that level. That is ectopic ureter, which is not in normal position. Here you see a case. Okay, a radiograph. See, this is bladder. Here some contrast radiography has been done. This structure is the ball of the Foley catheter. Okay, cough of the Foley catheter, not some pathology. Okay, now see the ureter. This is excretory urography. See this ureter and this is ureter. They are supposed to join at the neck of the bladder. Okay, but instead of joining at the neck of the bladder, they are joining at the proximal urethra. Female animal, this is vagina. Okay, so those contrast agents urography has been seen in vagina. Okay, the bladder drains to vagina. So now they are in vagina. Instead of going into the bladder, there is some portion which is growing, but very little amount, but the maximum is going to the vagina. Okay, they are directly joining into the proximal urethra. Okay, this is ectopic ureter. Okay, in case of ectopic ureter, you will find, okay, dilation of this ureter. Usually they are dilated. Usually they will be tortuous, like this one. Here you see. This is another radiograph. Here is the bladder. Okay, this is vagina. This is the ureter. Okay, they are dilated and tortuous. Here it is joining at the distal urethra. This is bladder, proximal urethra, and the distal urethra, or you can say this is pre-pelvic. This is a cat actually. I will tell you that in cat you will find a pre-pelvic part of urethra, then the pelvic part of urethra, then the distal urethra or the penile urethra. Okay, so they, in this case, particularly this case, the ureter is joining at the level of penile urethra. Okay, directly into the urethra. It is supposed to join at the bladder, but it is not joining at that place. So these are the cases of ectopic ureter which can easily be identified by excretory urography. Next, ureteral rupture. There is nothing you need to know. Simply when there will be rupture, there will be leakage. Okay, so here this is a kidney, this is another kidney, right, this is left. Okay, so notice the left ureter, it is going to the bladder, while the right ureter is not going into the bladder. Instead there is some leakage into the retroperitoneal space. Here I told you, for evaluating ureter you need an oblique view. This is oblique view. Okay, see here the left kidney, this is right kidney, and here you see the left ureter is going, this is cranial migration, then into the bladder. But here you see this is the ureter has been ruptured, so some contrast agent has been leaking to the retroperitoneal space. So this is ureteral rupture. Usually you will find these cases in case of trauma or accidents. Okay, so now let us go to the urinary bladder. We are done with kidney and ureter. Let us go urinary bladder. Kidney and ureter are upper excretory systems, and the urinary bladder and the urethra are the lower excretory systems. Now, urinary bladder. The left X-ray is of dog, right X-ray is of cat. So let us understand some normal anatomy and some differences. In case of dog, the bladder is usually oval in shape. While in case of cat, it is more or less ellipsoid. Second difference is the neck of this bladder. This is the neck of the bladder, usually found just cranial to, this is pubis, just cranial to pubis. Okay, so when there will not be any urine, just after voiding, this neck can go up to the just above the pubis, or some part will be inside the pelvic cavity. But in case of cat, it is always intra-abdominal. Okay, in case of cat. Okay, and here the urethra starts. Okay, it has a little bit longer neck, then the urethra will start. Okay, always intra-abdominal. So these are the basic differences between the dog and cat. You know the bladder has two ligaments, lateral ligament and the ventral ligament. Okay, which contains the fat due to which the bladder is visible. If there will be less fat, then bladder will not be visible. Okay, next, in the survey radiography, when you will take survey radiography, there is also a contrast radiography for bladder. So when you will be taking survey radiography, these are the some findings. If you are visualizing bladder and you are not finding bladder is not seen, but serosal outlines are clear, it means serosal detail is clear, but the bladder is not visible, then these are some pathologies. Many of them, you may find the perineal hernia. When the perineal hernia, it will be in perineal space. Okay, there might be good serosal detail, but bladder is not visible at its usual place. Okay, next may be inguinal hernia. We'll see some pictures also so that you can relate. Suppose bladder is not seen, along with the serosal detail is not seen. Can you tell which condition that will be? Peritonitis. Okay, peritoneal fluid. It may be exudate, it may be transudate, there may be blood or hemorrhage. Okay, Also, some point I wanted to highlight, if you will have some lack of peritoneal fat, especially in case of emaciation, there will normally will not serosal detail will not be clear. Also, in case of young animals which has more brown fat rather than white fat, less than 4 months of age, in that case also the serosal detail will not be clear. Those are normal things, okay, no abnormal things. Bladder may be some at abnormal position, cranial displacement, caudal displacement, dorsal or ventral displacement. Abnormal shape also, usually abnormal shape you will find in case of bladder neoplasia. Okay, abnormal size, increased size. Suppose there is ureterectosis, some blockage, the bladder will be size will be increased like that. We'll see some photographs. You can take a screenshot of this one and you can see those diseases. Let us see some radiographs. First radiograph, left one is case of perineal hernia. This is perineal hernia where the bladder is at the perineum. This is a case of ventral hernia. Okay, the ventral muscle wall has been ruptured due to some trauma or like that. The bladder is at the ventral space between the muscle and the skin. Okay, so perineal and ventral hernia. This is a case of cranial displacement. Okay, so bladder is supposed to be here, but it has been displaced cranial. This is bladder. Can you tell which structure is this? This is prostate. We will also discuss prostate in different chapter. So this is prostate. Due to prostate enlargement, it may be due to benign prostatic hyperplasia, it may be prostatic cyst, it may be prostate cancer. Okay. So all those things, when the prostate will too enlarge, the bladder will be cranially migrated or cranial displaced. Okay. So here the bladder is slightly distended, and also you will find some mineralization, which is basically the urolith. Okay, so these are some pathology which can be found in normal radiographs, normal survey radiographs. Okay, here something, here you see bladder is not seen and also the serosal detail is not clear. But remember, the retroperitoneal is clear. You can find kidney, very nice presentation of kidney. Retroperitoneal space is fine, but the peritoneal space is not clearly visible. Here you can see the spleen, okay, slightly clearly visible, but the border effacement between the intestines is gone. Okay, the serosal detail is gone. So this is a case of peritoneal fluid or peritonitis. Okay. Now here is another radiograph. See the bladder. Okay, it has a foamy appearance. I told you about foamy appearance in case of spleen. Okay, in the previous video I told you foamy appearance is basically due to when the gas producing bacteria proliferate. This is a case of cystitis in which there is foamy appearance, which is basically emphysematous condition. Okay, this is emphysematous cystitis. So these are some normal survey radiographs. Here you see, here some contrast radiography is done. I will tell you about contrast radiography soon. So here you see, this is the bladder. Negative contrast here has been used. This is negative contrast cystography. There is positive, there is double contrast, there is negative. Okay, I will tell you about all this. Here the contrast urography is also done. See the ureter. Okay, this is ureter. This is another ureter. They are actually joining at the urethra. Okay, here the contrast agent in the vagina. The female animal in the vagina. This is the case of ectopic ureter. This is the entire bladder. Okay, this is ectopic, case of ectopic ureter. Here you see this is bladder tumor or some maybe carcinoma or anything. See, this entire thing is bladder actually. This is abnormal shape. So when the contrast agent has been pushed, here negative contrast has been pushed. See, this portion is only highlighted or this portion is visible, but this is not taking the contrast. Okay, so there might be some pathology. Usually all the pathologies of bladder you will find in cranioventral border. This is cranioventral border, this border. This is cranioventral border. You will find most of the pathology in cranioventral border when it is focal. Okay, focal means at a particular spot, in this spot. If it is diffuse, then the entire structure will be affected. These are the normal survey radiographs. So next coming to the contrast cystography. Okay, so you can do positive contrast, you can do negative contrast, you can do double contrast. So in case of positive contrast, the 20% iodine solution is used. The dose rate or through dose rate in case of dog and cat is 3.5 to 13 ml per kg, but average you have to give 10 ml per kg. But there is a catch. So when you will be administering the contrast, whether positive or negative or double, remember that moderate urinary bladder distension is recommended. Okay, so when pushing those contrast agent, you have to externally palpate the bladder for distension. Okay, so it should be moderately distended. If you do severe distension, then there will be subserosal accumulation of the contrast agent. Also, it might cause some bladder rupture if you are not monitoring, and also over distension may mask some regions like the bladder wall thickening, especially the mucosal changes, and I'll discuss what is mucosal changes and intramural changes. Okay, they can mask if it is over distended. Another thing you have to remember while giving the negative contrast can be, the contrast agent can be room air, carbon dioxide and nitrous oxide. Okay, so especially when you are using room air, you may find gas embolization, okay, of circulatory system, though they are very rare, but it can happen. Now while giving the positive contrast, remember this one, moderate urinary bladder distension. By external palpation you can do that. You have to do this moderate distension. Next, double contrast. First we have to do the positive contrast, 20% iodine solution. In case of cat, depending on size, 0.5 to 1 ml. In case of dog, if it is less than 12 kg or 25 pounds, 1 to 3 ml. And if it is beyond more than 12 kg or 25 pounds, in books it is written pound in pounds, 3 to 6 ml. Okay, first you have to give the positive contrast, then apply or then inject the negative contrast and do the palpation for moderate distension of the bladder. Okay, so this is contrast cystography. Let us see some normal images first. This is normal contrast positive, this is positive contrast. I already told you, show you some pictures of negative contrast. This is positive contrast. Okay, this is double contrast, this is oblique view. Okay, notice the mucosal lining. This is mucosal lining. Okay, they are very thin, very thin. Notice I am erasing this one. Notice this. Okay, in centrally you will find the positive contrast. In the periphery you will find the negative contrast. Okay, this is mucosal lining or the bladder wall. Okay, this is bladder wall. This is normal picture. Okay, now when you will do the contrast radiography, you will find some changes which you have to notice for. First radiographic sign or radiographic change is mucosal change. I told you about the normal. You saw the normal photograph. See here. This is the dorsal border, which is kind of alright. This is the ventral border, which is slightly thickened. Okay, notice the cranioventral border. It is broad type. Okay, there is some more increase in radio opacity like this. Okay, so these are basically mucosal changes. Mucosal changes means hypertrophy of the transitional epithelium. Okay, there will be some, not only hypertrophy, there might be some tear, some loss of transitional epithelium. Okay, so those can be seen. You see this structure. This is a cranioventral margin. Mostly this margin will be affected. So this is basically a case of cystitis. Mucosal change, and mucosal change means when the transitional epithelium is there is some change in transitional epithelium. Intramural means inside the wall. Okay, there is mucosa, there is some mucosa, there is the muscular layer, then also serosa. But inside the wall, when there will be change, that is intramural. We will discuss also. Mucosal change is only the border, the inside border. Okay, this is inside border. So this appearance can be of a broad type, which is here broad type, to cobblestone type. Severe cases you will find cobblestone type. Okay, here it is kind of focal, only up to this region it has been affected. Okay, but the dorsal border is slightly fine, so it may be focal or entire thing will be there, which is basically diffuse. I told you about focal and diffuse. Now here you see the positive contrast. Here is the positive contrast. Can you see some filling defects here, 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 here? Okay, so here the filling defects, the shape is actually irregular. Shape is irregular, and also the borders, the margin is irregular, and also indistinct. Okay, these are the feature of blood clot. I will also discuss regarding the filling defect for cystography point of view. Okay, these are blood clots. If these margins, okay, this shape is irregular, but the margins are kind of regular but indistinct, that is stone, uroliths. We will discuss also. Let me show you the next picture. The next change is intramural change when the bladder wall is thickened. Can you see here? See the bladder wall, it is thickened. Okay, this bladder wall is thickened. Okay, this is intramural change. Okay, usually they coexist. Okay, not necessarily that you will find separation between these two changes. Okay, here you see the filling defect. Can you see the filling defect? This is the positive contrast. See here, this. Okay, the shape is sometimes may find round. Okay, like oxalate stones. Okay, urate, they are kind of circular, and the margins are indistinct but regular. You see, you can see some margins, but usually they are indistinct. Okay, but you can see the margins. Margins are comparatively nicely visualized. Okay, so these are basically calculi. Here you see this one. This is basically cuff of the Foley catheter, not a stone. Okay, so you have to see very carefully. Here you see the bladder wall is highly thickened. These are intramural changes through this double contrast radiography. Double contrast cystography. Cystography is also radiography. Okay, so you can find these changes. Next is filling defect. I was talking also in case of ureter. I told you the filling defect. And also in case of cystography there is filling defect. There are some things here. The important is calculi, usually you may find blood clots and ureter cells. Okay, but also you can find all those changes. I told you in case of calculi the shape is may be found rind or slightly irregular, and but the border is indistinct but regular. In case of blood clots you will find irregular shape, the border is irregular as well as indistinct. Okay, so these two are differentiating. Also you may differentiate between the neoplasias. Okay, neoplasias usually they are not free. Okay, stones are free. Blood clots, it may be free or it may be attached. Okay, so those filling defects can tell you that what is inside the bladder. But you see, the best is ultrasonography. Okay, there is no deny that radiography is better than ultrasonography like this. But if you do not have a facility, you can rely on the radiography. Take a screenshot of this one. You can note down and read upon them. Next, ureter seal. I told you about ureter seal. Why I am telling about ureter seal? There is a characteristic sign. Okay, that is cobra head sign. Cobra head sign. Who knows, in JRF they might ask some like these questions. Cobra head sign. Okay, I already discussed about Bates bodies in case of peritoneal space. If you have not seen that video you can see that. So here this is bladder. This is bladder. See here, the ureter is coming like this, and before entering into the bladder, you can see there is a bulge. This is a convex bulge. Okay, this is the feature of the ureter seal. Okay, but when we will be doing the positive contrast, this is exclusory urography. But when we will be doing the positive contrast radiography, see the characteristics. See, this is trigone area. Okay, this is trigone area. Usually this feature or this ureter seal you will find in case of trigone area. Okay, so in that area you see this part has not taken up any contrast. This is basically uretero seal. So it looks like a cobra head. Okay, so cobra head sign. You may not find these cases in your clinics or in your departments, but you should know that these type of cases can be there. Next, The radiographic sign, or I told you about three: the mucosal change, the intramural change, and also the filling defect. This is the fourth one, that is contrast leakage. So the contrast can be leaked into three types or three spaces, you can say. First one is into the urinary tract. Second one, it can go up to any hollow organs, nearby hollow organs, through a fistula, like the colon or the vagina in case of females. Third, it can leak into the peritoneal space. Okay, so here you see leakage into urinary tract. It means that when there will be urachal anomalies. Okay, suppose there is urachal diverticulum or persistent urachus, like those cases. Here you see this is the bladder. Okay, and here you can find some thing. This is basically a case of persistent urachus. So here you will find some positive contrast agents. Okay, this is urachal anomaly, some problem with urachus, that is taking of the contrast. Okay, this is leaking into the urachus or leaking into the urinary tract. Urachus is basically part of the urinary tract. This one is leaking into peritoneal space. See this bladder. Okay, there is a rupture of the bladder, so the contrast agent has been entered the peritoneal space. Okay, so this is leakage. This is a radiographic sign in case of contrast radiography. See, in ultrasonography, the artifacts, they provide good diagnostic tool. Like this, in case of cystography, the radiographic signs will provide you good diagnostic value. Okay. Next, some disadvantages, or you can say downfall of this cystography. There are two types of pitfall or downfall or artifact, you can say. First one is the air bubbles. The second one is pseudo filling defect. The first one is air bubbles. Air bubbles can be three types. Air bubble artifact. First one is small. Second one is second one is large one. One large bubble. Okay, this is large bubbles. So these small bubbles, you see, these are the small bubbles. Here, small bubbles. Okay, small bubbles. See, the bubbles, the margins, the shape is usually circular, but you can identify the shape. And the margins, specifically the margins, unlike the blood clot and the uroliths or calculi, the margins are very much clear or distinct and regular. Okay, in this way you can know that these are basically air bubbles, not some any pathologies. Okay, so here when there is multiple large bubbles, okay, you may find honeycomb appearance. Here you see one large bubble, here one bubble, here one bubble. Okay, here one bubble, like this. Okay, this is honeycomb appearance when you will have multiple large bubbles. Okay, and when you will find single large bubble, here is a large bubble, what will happen? They will push the contrast into the bladder wall. So you may diagnose this one as bladder wall thickening. Okay, so you have to know about these artifacts. This is pseudo-filling defect. What is pseudo-filling effect? Here the bladder is not shown actually. Bladder is, suppose it is like this, but when the bladder is actually not distended moderately, it is slightly less distended, then you can say that the bladder is inadequately distended, to giving a false impression of some pathology. Okay, so this defect can be corrected by the distension. You have to distend slightly more or to the moderate level, then you can find some do the positive contrast, or you can find some pathology if it is there. Otherwise you may diagnose this as some pathology, especially in books it is written when you will find pseudo-filling defect, it is usually diagnosed or misdiagnosed as neoplasia. Okay, so you have to know about these defects. Okay. Now let us go to, this is all about the urinary bladder. Let us go to the urethra. So this is urethra. This is of a dog, this is of cat. Some normal anatomy. In case of dog, you will find the prostatic urethra. After this, the membranous urethra. After the ischia, this is penile urethra. In case of dog, this is up to the pelvic urethra, usually pelvic urethra, but this is pre-pelvic, this is pelvic urethra. Okay, usually the neck is slightly longer, so you will find a smaller, sorry, I actually marked wrong. The neck is up to this level, they have a longer neck. So the urethra has some pre-pelvic part and the pelvic part up to this one, pelvic part, then the penile part. The thing is, you have to remember here actually the prostatic part is not adequately dilated. So the prostatic urethra is usually have larger diameter than the membranous urethra. This is prostatic, this is membranous, this is penile. And the penile urethra has a uniform diameter. You can see it is uniform diameter. Slightly variation will be there because the contrast agent may not be adequate to dilate it adequately or uniformly. But some slight variation is fine. But it is there is big variation, then there might be some problem. Similarly, in case of cat, the pre-pelvic and the pelvic part is usually have a larger diameter, but the penile urethra has very small diameter. Usually, they are not much distended like the pelvic urethra. Okay, so this is basic difference in dog and cat. Let us go to some the urethropy. The contrast agent, the contrast radiography of urethra is urethropy, bladder is cystography, then the urography. Urography is basically the entire system. So the retrograde urethropy, fasting is always needed. Then the bladder should be distended before doing the urethropy, because when the bladder will be distended adequately, it will put counter pressure on the urethra so that the urethra will be adequately dilated. Okay, dilated, not diluted, sorry. So then you have to do the catheterization. You may use Foley catheter or you may use, in case of cat, Tom catheter. Okay, so the Foley catheter has a cuff, then you have to inflate the cuff. Usually the catheter is inserted into the distal urethra. Okay, let me show you. See here, here the catheter. It is only up to the distal urethra, this level, distal urethra. Okay, just proximal to the os penis. This is os penis, just proximal part of os penis. It is inserted and the cuffs are inflated. Okay, then you have to push the contrast agent. So the cuff inflation, it should not be beyond more than 15 minutes. Okay, it should be less than 15 minutes. The cuff should be inflated less than 15 minutes, because if you will do much longer time, then there might be some damage to the urethra. Okay, next the contrast agent, depending on size of the animal, 5 ml to 20 ml of contrast medium can be injected, and radiography is acquired during the last 1 to 2 ml. When you are injecting last 1 to 2 ml or the final 1 to 2 ml, then you have to take the radiograph. Okay, for this also you need lateral radiographs, ventrodorsal radiographs and the oblique radiographs. So first pathology which you can diagnose, commonly diagnose, is urethral calculi. See this urethral calculi. These are the two images. Okay, one is real, one is artifact. Can you tell which one is real, which one is artifact? I have discussed regarding the filling defects. So this one is the real, this one is the artifact. Okay, here actually air bubble is present. I told you regarding the first you have to see the shape. Okay, here you see it is irregular shape. Irregular shape. While it is more of regular shape. Okay, regular shape. Next point is, you see the margin. Margins are indistinct. Okay, there is some effacement, border effacement. Margins are basically indistinct in case of calculi. In case of blood clot, it is irregular as well as indistinct. Another difference is, when there will be urolith, in the normal survey radiograph, you will find urolith, but blood clots are not visualized. By that also you can differentiate between the blood clot and the urolith when you are doing survey as well as the contrast. So here I told you the margins are indistinct, but here the margins, see the margins are very much distinct. Okay, next point is where this calculi is present, the urethra is usually dilated. Okay, but look at this, urethra is not dilated. Okay, not dilated. Another thing, if you will take multiple radiographs, the position of the calculi will not change, it will be here only, but the air bubble, it may migrate, sometimes it may be here, next radiograph it may be here, it may be here. Okay, and also the calculi usually are focal, but in case of air bubble you may find multiple air bubbles. Okay, these are the basic difference when you can tell the artifact and the real calculi. Okay, so this is urethral calculi. Okay, next pathology we will go to, this is some artifacts actually in case of in diagnosing the urethral calculi. Here you will find some radio opacity, but this is basically teat. Okay, teat. When the teat will be superimposed, then you may misdiagnose this as urethral calculi. Okay, so you have to take care. Another thing, there in some dogs, okay, you may find a different center of ossification of this os penis, which may be misdiagnosed as urethral calculi. Okay, so these are the some artifacts which you need to know. Next is urethral neoplasia. So the urethral neoplasia, in this case you will find some filling defects. First of all, urethral neoplasia can happen inside the lumen or the wall. When it is inside the lumen diameter will increase, while if it is in the wall, the diameter will decrease. Okay, and also you will find filling defects, like here you see some filling defects. Here it has been increased, then it has been decreased, then it has been increased. Okay, usually the urethral neoplasia is associated with prostatic neoplasia. Okay, they usually migrate and invade into the urethral space, urethral lumen or urethral wall, causing these filling defects. Okay, so this is basically the urethral neoplasia. Next is urethral leakage. Urethral rupture. Due to rupture you will find leakage. You will see here, you see the catheter is inserted into the distal urethra. Okay, then after you have to give contrast agent. Here there is urethral rupture where the contrast agent has been deposited in the periurethral space or leaked into the periurethral space. Okay, next urethral fistula, which is also a part of urethral leakage. Here you can say this is the urethra and there is leakage into the anus. This is anus. Okay, this part which comes outside is anus. So there is some fistula. Okay, it may be congenital or it may be acquired. Okay, so this is all about the urinary system. Okay, the excretory system. In case of dog and cat, this is a marathon lecture. Usually my lectures are slightly bigger, but I hope they are very much helpful to you. Okay, next we will go for the prostate and other structures. Till then, see you, tata, bye bye, take care.